But yeah, again, I'd like to thank you all for coming. I know that the numbers will increase exponentially as the program progresses. But yeah, again, I'd like to thank us for coming out to hear, not even, well, I should say listen, because you have to be active. So this afternoon we're looking at child and adolescent depression. I won't be the one to present it. My esteemed colleague, Dr. Kaj, will be doing that. In the interim, please prepare your minds and your hearts to hear what he has to say. But I'd also like to say that this month we are coming together every Sabbath from now until the ending of the month to focus on God's greatest gift to us, our health. Not only, well, health in a wider context in terms of mental, physical, and even spiritual as well. In a world full of anxiety, fast living, and health misinformation, we believe it's more important than ever to equip ourselves with truth, understanding, and support grounded in faith and wisdom. We are honored to host a dynamic lineup of health professionals. Dr. Kaj is one of them, who are here not just to inform us, but to engage us, empower, and inspire us to live whole and well-adjusted lives to God's glory, where we tackle real issues that we're liable to face. Over the coming weeks, we'll be covering things, for instance, like diabetes, medical emergencies, and also looking at if you're diabetic, if you're at risk of diabetes as well. At the end of the month, we'll be having a lineup of our 4 presenters, where any questions that we weren't able to answer or answer in a way that you'd expect, they'll be back to answer those questions. And that'll be a forum of 4. But in between time, let's journey together so we can honor God and also bless our community with the knowledge that we acquire by being here and throughout the month of May. The reason why it's throughout the month of May, because sometimes you cannot get as much information in one sitting. You cannot digest it, you cannot understand it. So that's why we've given the entire month of May over to health emphasis. In the same breath, those presenters who avail themselves of coming to Ilford Central, which we thank them for, they'll make themselves available even after the program. I believe that it'll give you hopefully give you any information that you may need to equip you so you can be healthier and more knowledgeable about not only about your body, but in case there's anyone else who may be experiencing any kind of ailments that we discuss, you'll be able to inform them in terms of what we've received here. So, before we begin, allow Sister Kathy to come forward and offer a word of prayer.
Afternoon. Okay, shall we just bow our heads and just ask God to continue his presence with us, yeah? Dear Heavenly Father, just thank you that you've continued to be with us throughout this week. We're just asking now that you bless this time and that you help us, Lord, to open our hearts and our minds to what we're being taught. And Father God, you know that you wanted us to be healthy in spirit, in body and in mind. So right now, I just pray that you'll bless the speaker, that he will speak on your behalf, Lord, and that we will learn according to your will. So bless everybody here, bless everyone in your hearing. In Jesus' name I pray, amen. Right, I've known Dr. Kaj for a good number of years. He's one of our consultant psychiatrists over at Newham Center for Mental Health. And I can assure you that whatever information you get today, take it with both hands. Because he knows what he's talking about. He's a knowledgeable man. But one thing for sure is I'm not going to say more than what I'm saying now. I'll let him say who he is and his background and so forth. So at this moment in time, I'll ask Dr. Kaj to come forward.
Hi, everyone. So I'm Kaj, or Dr. Kaj, as most people know me. I've been in Newham as a baby doctor, actually, for nearly 10 years, worked my way up. This one, is that more clearer? Yeah. So I've been working in Newham for roughly 10 years, starting as a very junior doctor, or baby doctor, and working my way up. And as Clem said, I'm now one of the consultants in inpatient psychiatry. Thank you for inviting me to talk about depression. We're thinking about raising awareness and understanding, thinking about how to break down barriers and make sure that as a community we can come together when people are in need and in need of help. And in doing so, I'm really appreciative of being invited here to talk to all of you today. Just need to know how I get the slideshow on, really. Will it pop up for me, or? Thank you. So as the title says, this is about raising an awareness about depression. The aims today are to break down some of the barriers, the stigmas that we may have about mental health today around depression, to help understand and pick up on symptoms or signs that our friends, our loved ones may show, and how to seek help and how to feel that people are approachable, from whether it's our relatives, our GPs, or psychiatrists. With depression, it's roughly 4 to 10% that I would say get into very, very difficult times, and we will say the severity of that is known as clinical depression. There can be up to 5% of when these symptoms, these difficulties may be more persistent, and they may last longer than one would wish for, which is why we're trying to think about who is around us, who could be having these difficulties, and how do we help them to recognize those. When we think about where care can be then received, 90% of this can be in the community. It doesn't mean that someone who's struggling with their mood, these difficult times, that they have to go into hospital. By reaching out and speaking up about what we're facing, what we're observing, we can help when we're in our homes, when we're in our workplace, to really think about how we can move forward. And there are many people who suffer with these symptoms, and so this is why such an opportunity as today can help. So is depression just feeling sad? Is it just feeling down? So what people may think we feel is sadness, complete sadness. However, there's much more to that. Maybe we're feeling a sense of guilt. We might be feeling lonely or isolated. Often sadness is a smaller part of this, a sense of nothingness, a sense that we're not even here, a void, is often a feeling that can be very profound and very difficult to describe. When we think about depression versus sadness, depression is going to be a longer period of time having these difficulties. So if we're feeling a sorrow, if it's a couple of days, we usually overcome that by being able to think about things, speaking up. And such feelings can happen at any time in our life. It could happen briefly, it could happen more recurrently. And the way that others may see this in ourselves, or ourselves seeing what it could be impacting on, we call this social impact. So the sense of feeling sadness, feeling empty, can really affect the people around us. So maybe the relationships are getting more difficult or tiresome for the individual. Maybe you'll notice that they're struggling to do the household chores, to maintain their home. Maybe work is starting to be impacted, struggling to get to work or to feel focused there. Usual hobbies or activities could be more cumbersome, more difficult to attend to. And often people want to keep to themselves in these times. So seeking help can be harder for them. The kind of features that we would say with depression would include feeling down, a low mood, would be having a lack of energy, profound tiredness, maybe not wanting to even get out of bed, and that tiredness persists throughout the day. could be a loss of interest, so things that they used to enjoy doing lacks that pleasure anymore. Maybe they don't wish to go to it and they're trying to avoid those things now. It can affect our sleep. Even though we're feeling very, very tired, we can struggle to fall asleep or even stay asleep. Perhaps sleep itself is disturbed. We're getting less hours. Others may have more hours and yet still have that profound feeling of inattention and tiredness. Their appetite can change. We can think about lacking pleasure from eating, not feeling hungry. Often you might notice this in others when their clothes look baggier. Maybe they've noticed some weight changes happening, so losing weight. The intimacy between a relationship may change. And generally when we're having poor food intake, a lack of movement, our body starts to talk to us. We may seem having more aches and pains around us, headaches, and our stomach or our digestive tract may change itself as well. Concentration is one of the first things that people start saying. I'm really struggling at work, really struggling to understand what you're saying. Can you just give me a moment? Could you slow down with what you're talking to me about? Come back and talk to me later. Maybe they're forgetting to do things that they were meant to do. Prioritization of tasks may reduce. And in doing so, feeling worthless, that they can't do anything, there's no point in doing it. Feeling hopeless that nothing will change and continue down a spiral. And in doing so, spiraling down, starting to feel a sense of guilt that they should be better than this, that it's their fault, blaming themselves. And starting to withdraw from community activities, family activities, wishing to stay at home more, wishing to stay in their room more. And as those thought processes change, as those driving low feelings arise, maybe they think about escapism, a way to end it all. Some people talk about cutting or tablets, and they may be collecting some things, which might be one sign that you want to keep an eye on. The way depression can come about can vary in the age groups as well. With children, maybe it's more irritability than feeling sad. Maybe there's more defiance against their adults, their teachers, their parents. With older adults, it might be more subtle. Low mood might seem just a little bit on the lower side than something that seems more profound. There's more of a slowing down. Maybe they turn to other substances to try and manage the day-to-day. With children, it can be particularly difficult to pick up on certain aspects. It's much rarer to see in young children. The network that one may have for kids really derives from the nuclear family, which we say are the parents and their siblings, protected in the home environment. And as they get older, their social network increases, becomes more friends, school, outside of school. And as that progresses, there's more responsibility on an individual. As they grow up, more tasks become orientated towards themselves to manage, and then their education as well. There's more drive of being responsible for one's well-being there. So as we get older, it becomes more common. And often we see this more within female population than the male population. Again, is it just feeling sad within kids? Would that be one of the signs that we would see predominantly? When we think of infants, it might be that there's an apathy, a lack of interest to do anything. They may come away from their family or playtime. Perhaps developmental milestones are not being quite met. And as we get older, similar aspects could be monitored. So with kids, again, are they spending time with family? Are they spending time with friends? And if they're not with them, what are the tasks that they're doing? Could be changes in their daily routine. So is their sleep disturbed in some way? Their eating habits, has that been changing recently? Do they get quicker to feel irritable or to feel overwhelmed? And are there lingering pains, often stomach aches, headaches, unexplained, and the persistence towards that? So little nuggets of information that a child may be expressing when they themselves aren't attuned towards what's happening in that feeling of depression. Some may try and overcompensate with those difficulties and try to please others. It's a smaller portion that try to overcompensate, in fairness. As we get into adolescence, similar aspects. So one is getting older, there's a wider network, they spend greater times with others, different proportions within family and friends. But is that changing more recently from the usual habitus? Is the attention struggling now? Let's say now we're at school and we're having other homeworks and aspects that we need to be focusing on. Are they maintaining their hygiene, their health? Are there more outbursts, greater frustrations that seem out of place, not in keeping with what the discussion was at that point? Some may turn towards substances and dabbling within that, depending in the environment that they have access towards. They may develop different eating patterns, eating habits. That can often be a very typical sign of an early change that's occurring. Self-harming. It's not always cutting. It could be hitting oneself, head-banging, pinching their skins, leaving marks, bruises, which may dissipate over time. They may start talking about escapism as well. It would be have actions started to arise where we start thinking, should we be seeking greater immediacy of help in those cases? In school, there will be a greater proportion of time where kids are now spending away from the family. Perhaps teachers or those around are suggesting that there's been a change within their behaviors, within the lessons that they're having. Maybe they don't wish to stay in lessons and there's detentions or truancing that's occurring. Self-care may change. The focus on the work at hand and then struggling with their homework afterwards. Shouting out, acting out, irritability may be more in play in the school position, and teachers suggesting that there's a defiance that's arising. Are they actually not going to school anymore? Are they really finding it a struggle to make their way there and wanting to avoid situations from arising and therefore staying away, avoiding the situation may help them to try and cope? Have they started withdrawing from that network of friends they have and the teachers they trust? Substances could arise at school. There's more phenomenon around vaping. Have they been hurting themselves at school? Often teachers and liaison advisors will then be reporting this to the family members. So when we treat these difficulties, how would we treat these difficulties? First, highlighting what we're observing, the symptoms one may be having, or the difficulties we're seeing, a change in their routine, a change in their behavior. When there is talk of harm and worries or actions in that degree, it would be very important to raise awareness to the health services, the GP. By seeing the GP, they'll be able to piece that all together and help the education of the individual to see a future when sometimes that spiraling down is absorbing them into that. the GPs will be able to decipher between the severity of symptoms and the number of symptoms. It's not often that we need lots and lots of things in all of those domains we've just been discussing. It could be that there's one very, very profound feature and some other aspects that are then being affected upon this. The symptoms when we think about depression, it needs to be there for about 2 weeks. Often those difficulties at low intensity, they could be resolving. It could be that having an understanding of what's happening and being supported by their family helps to reduce the difficulty they face. Does it affect daily functioning? We could feel low, we could feel wanting some time away from situations. But when it starts affecting the way they look after themselves, struggling to get out of bed, struggling to mobilize, to get outside, not really eating, neglecting themselves, that becomes more concerning, and we would want to try and address that with the individual, help them to see that something's changing, and then to see what services such as GPs could help with. When we think about how the symptoms are and how it's affecting the daily functioning, then GPs and psychiatrists will think about the severity of how it's causing those problems. And they categorize this into mild, moderate, and severe. When we think of severe symptoms, that's when we start thinking about clinical depression, and it might need some assistance more into hospital. Mild and moderate, as we said, 90% of depression could fall into those categories and are assisted at home with a GP and with the local community. So if we were to think about mild, moderate difficulties within depressive symptoms, it could be watch and wait, see how things go, acknowledging there has been some difficulties, and the resolution will arise from that. Sharing about those triggers that have caused difficulties, the ownership that's felt that we have to get over this by ourselves. It's not true. We have people who care for us around us, and we have the support network within healthcare service that want to help us to overcome these challenges. And that's where education comes in, to understand that they're not alone, family's not alone in this, and there are ways to move forward. The aim with education or psychoeducation is to break that idea that we are worthless and hopeless and there's no future, no way of getting out of situations. It's showing the options and the pathway forward that can make it much easier to digest and take those steps. Could be looking at school adaptations for children, helping teachers and the school network understand that the child is going through some support needs. There are psychological interventions. We know these as counseling or cognitive behavioral therapy. Talking to someone for a couple of weeks might be very, very helpful. Doesn't mean that medication is always the answer. And as we get towards moderate and severe symptoms, adjuncts, so alongside the psychoeducation, psychology, there are treatments. We know them as antidepressants. For children, the antidepressants are slightly different from adults, and again, the GPs will be guided on which ones to use. Otherwise, the symptoms may worsen if the wrong antidepressant is used, thinking that the treatment given for adults would be the same for kids. But these medicines often take time. It can take up to 2 weeks to see some changes arise for some of those physical symptoms. It could take up to 4 weeks to see that mood and energy arise as well. That's a generalization for this. Some people will find a change within a week, but often the general aspect will be about this time period. So it's really important to think about the network around, the understanding about these difficulties, and taking some time away from the stresses that may have been triggering. How long would we need to be on treatment for? It's really between the individual and the GP. Sometimes it could be resolving within that 2 weeks. Sometimes with medications, we'll need to take a bit longer, and it could be for a few months, 6 months, depending on how a client is finding the treatment, how they're finding the re-engagement to the routines that they used to do. And sleep advice. We know sleep will be dysfunctional when we're having these difficulties, the focus and thinking about the sadness and worries that we may have. But trying to fill that time with something, often people turn to tablets and their mobile phones, and these things stimulate the brain to stay awake and alert. It perpetuates the difficulties for sleep cycles. And when we're having sleep problems, this is one way of adjusting to make sure we maximize the benefits and recovery potentials. If we're not having sleep problems, perhaps our colleague is able to use the phone before they go to bed straight away. But when we're having these difficulties, let's adjust what can be most beneficial to us. Exercise. Exercise doesn't suddenly mean go to the gym and become a bodybuilder. Exercise means getting a routine, getting the heart pumping a little bit, getting a bit out of breath, maybe more regular walks around the block, brief jogging could be good. Exercise is about forming a lifelong positive habit. One of the methods that I often suggest to my clients is thinking about swimming. Cold water has been shown to be very efficacious for improving one's mood, improving the body. When we thought about those joint aches and those problems, water helps to support the body's health in itself. And then we have healthy eating. General sound principles for having a good diet, having healthy mind, healthy body. Fatty foods, oily foods, they tend to be more sluggish for us when we're thinking about our energy levels, and then the health benefits of having a balanced diet will have its merits towards these symptoms as well. And socializing. We were saying how people tend to withdraw when they're having these difficulties, want to stay alone. So being invited into the family time spaces, coming out into community spaces can be very uplifting. The types of risks for depression, perhaps there's family who have had these difficulties, perhaps in the past we've had these difficulties. So it leads to the potential for maybe having predisposition towards this. Has there been major life events? Have there been difficulties that have been very hard to overcome by themselves? These can be things such as bereavements, relationship changes. It could be, particularly with children, have there been difficulties at school in bullying, being neglected? Stress for adults and children can relate towards exam performances. Has there been changes in their management of finances? Has there been reduction in these things? Do we have chronic health conditions? Sometimes conditions such as breathing problems, heart problems, can lead us to having life-changing management strategies. Perhaps we're not able to go to do those exercises as much as we wish, to get out and about anymore. Perhaps it's more difficult to manage insulin. And so these kind of aspects can make us feel more worried about our general well-being, our mental health, and can make us to feel sadder. In those cases, maybe it's thinking about how our physical health is managed, rather than thinking there's another difficulty that needs to be reviewed. Medications that may have been started could make us feel differently. And so it's very important to know, when did something change, and had something arisen around that time that could account for these? Generally in the population, male, older age, and isolation, there are typical phenomenon of saying perhaps this individual might be at greater risk of developing a depressive symptom. it might not always be depression, and that's why it's important to see the professional, the GP or the psychiatrist. Although we may highlight symptoms or difficulties, it's important to bring that to the attention of a professional so that they can scrutinize it and think about it pragmatically. Because there's lots of other things that can make us feel lower, can make us feel tired. Our body might be going through hormonal changes, of which things that affect our thyroid, things that affect electrolyte balances, they can all have depressive features but have a very, very different treatment regime. Anemia, a lower blood level, kidney problems, liver disease, these can all make us feel down, but again, the treatment for it is very, very different. And there could be something within the bone structure of the head, and that's why it's important that GPs can do their investigations, blood tests, scans as required. But the history, talking about what's been going on, that is about 90% of any clinical review. Investigations then help us to discern that this is what we're thinking is happening. And comorbid illnesses, as we're saying, if there are chronic health problems, perhaps the sadness one is feeling is related to a change in their physical abilities, or that their routine or life will need to be adapted in some way. These can include epilepsy, multiple sclerosis, memory changes, strokes, and heart problems or diabetes. There are other conditions where mood can change dramatically depending on how the seasons are. We call this seasonal affective disorder. Typically in the winter period where there's less natural sunlight, that's when someone might feel more down, feel a lack of energy, those depressive type symptoms. And then as we get into the spring, summer period, it almost switches around and maybe a bit more irritable, appetites changing. Again, the GP will be able to discuss this with the individual, providing the individuals raise an awareness of some changes that are occurring around that progression of the year. It could be that the depressive symptoms return and recur. There are sub-levels where we feel a little bit low all the time, and we refer to this as dysthymia. Doesn't affect the functioning for us. We are able to go out and about, get on with work, complete the tasks we need, but always have a background sense that we're not quite where we should be. With persistent delusional disorder, it's a long-standing chronic disorder where perhaps we can have a period of recovery, or shall we say stability from those symptoms, but it may return again, and the time period for that can be very different for individuals. Sometimes it could be a couple of weeks, sometimes a couple of months or years, but often it returns and persists, and that can be very frustrating for the client thinking about how will they manage their day-to-day. With treatments and psychology in particular, it's a very effective way of overcoming this difficulty. For children, there can be other conditions where why are they seeming a bit irritable, low. And these can be around autistic spectrum disorders, learning difficulties, or even conduct disorders. And that's where a psychiatric specialist will be able to gather the history from families, from the school, and make sure that the right form of treatment and support is provided, because these will be managed in a very, very different way to what depression would be. The schooling system would provide adaptations, special education needs support workers. So very, very different. When one is having a baby, then we can go through depressive features, could be whilst we're pregnant or even as we've delivered. It could feel very profound, huge exhaustion, huge anxiety, and then a sense of not fulfilling the maternal duties there, which can make the guilt and loathing arise. This can be in the first 2 weeks, and it's as the hormones balance out that we overcome these. But if they persist for longer than 2 weeks, then we start thinking about the depressive side. Thank you. Conditions such as bipolar affective disorder, where the mood can go very, very low and depressive, or go very, very high, manic. When depression arises and is profound and persisting, this is something that might be kept in mind. Manic features would be very similar to thinking about flipping everything the other way round. So if I'm not tired, I'm very energized. If I was struggling with focus, I'm now hyper-focused on multiple things. And sometimes with profound depression, our reality and experience of reality may change. And we can think about the psychosis, where we start believing in untruths or uncertainties, but requiring an explanation of why we're feeling these things, or hearing different symptoms. And again, these would be very important to raise towards professional assistance, because they will require inpatient treatment to ensure that the individual is safe and supported. So when we think about prognosis, recovery, as we're saying, the mild to moderate diagnosis of depression, spontaneous recovery is very, very pertinent and can be far more likely. Sometimes just that expression that I'm going through a difficult time, sharing that is very helpful for one to overcome. And then that psychoeducation, psychology, just to get on top of that. With moderate to severe, maybe medication would be required to assist to go further. But otherwise, with these two, GPs can very much manage the care. So you could be at home, taking some time off of work, making sure that family are aware of the difficulties to help with the home environment, and making sure that we're keeping on top of the difficulties we've raised. As I say, 90% will be able to be treated in primary care when it's within this degree. When we get to severe and we think about clinical depression, it may be that coming into hospital will be helpful to overcome that initial hurdle, get the treatment, get the physical health checkups before returning home, and then being supported by the professionals, home visits, weekly checkups. It can be around 6 to 8 months of treatment. That doesn't mean you're in hospital for that time, but it means having the support, maybe the medicine, to continue that stability. And when I've had clients who have initially been initiated on antidepressants, after a month, 2 months, they're feeling very well. It's very important to maintain that treatment. It's not like antibiotics or bumping your arm and having a short course of a treatment. It's very important to maintain that stability and then slowly come off of medications. GPs, psychiatrists, they'll guide in those changes. The reason it's important is when we're feeling well, we want to maintain that well-being. We want to maintain that understanding, because if we stop too early, if we don't keep up the routines that help us, there's a recurrence within 5 years of about 70% for severe depression. So when there's these increased risks, when we think of severe depression, the worries of their individual safety, their self-care, their engagement, it's really important we think about coming into hospital, psychiatric services, to get on top of the well-being and the mental health of this individual. Take-home message, hopefully you can see that. So when we see sleep changes, tiredness, mood, maybe irritability, someone feels more anxious about what's going on around them, concentration's changed, maybe they're turning to other substances to try and cope, or they're becoming more reckless in their actions. It's really important to think about something's changing. How do I provide support? How do I provide the education for this individual? And how do I make sure help is achieved so that things do not progress into more riskier situations or worsening of symptoms. So thank you for listening to me, being a really attentive audience. Is there any questions you would like to ask? Hi. I think they're going to get a microphone for you.
Thank you for speaking to us about this important issue that is facing us today, from children to adults. But the one thing that stuck to me was, how do you differentiate? Because there's a lot of awareness about dementia, loss of memory, and forgetfulness and loss of memory. But then in it there is depression as well. So it's slash depression, or so when do you differentiate, or how do you differentiate or the two? Depression, which is the loss of memory, as well as dementia, which is loss of memory. How do you differentiate that? How do you recognize? How does one recognize that?
So it's a very good question. So with changes to cognition, there can be other factors towards that. One is delirium, so signs of infection for acute change. When we think of memory in terms of Alzheimer's, dementia, these are things that happen generally in the older adult population, early onset maybe in late 40s, but we would see changes around 60s onwards if there was a dementing process occurring. And yes, you're right, these can often first come with irritability, low mood, changes in routine, and they could seem very, very similar because the individual is noticing something's not right with them, they're trying to work it out, and it frustrates. There are examinations for that, looking at specifically memory tests. So there's questionnaires that the doctors will do, and there are head scans that they can do as well. But they will be looking at all of this in tandem and ensuring with collateral, known as, have family noticed this happening over time? Is it a sudden change? Are there other explanations? As we get older, we get more physical health changes, possibly. And so they need to scrutinize all of this. So there can be a bit more workup in terms of blood tests, scans, but a lot of it is also taking good histories from the individual and those around them. Then they'll be able to put this into place to say, do we think it is purely depression, or do we think depression is a feature of something else going on organically, as you were saying, the dementia?
So do we, the same person, like, what's your status, you said? A fellow, a consultant? What did you say your status is?
So I'm a consultant in general adult psychiatry.
Yeah, general, yeah. So do we come to you for these same two problems? Are you able to tell us, talk us into this? If we come and say this is how you feel, are you able to identify the two?
Yes, GPs would be able to do this as well, because first, primarily getting access into knowing something's changing, we need assistance. If there is a memory impairment change, maybe the individual who's suffering through that may not recognize it and not want the help. So often it's then GPs coming in to review what the home situation is like. Forgetfulness can be discounted, so they may say, oh, I just put my keys there. Oh, yes, I left the gas on, but I was going to do something. Those are red flags. It's kind of going, well, hang on, something's not right here. The individual safety is in question. Let's visit them and see how they are, and that would often be GPs first. Well, actually, probably family recognizing this first, and then wanting assistance and advice, raising it to GPs. GPs may try to see, and then when there are concerns about the safety of the individual, self-care, or the environment at risk in some way, that's when they may seek assistance with a psychiatrist to say, we need to come in. Perhaps this individual is not so aware of what's happening for them, And so how do we bring them, as I said, to hospital, the tertiary care, to make sure, can we help, can we review, can we make things feel safe and understood by the individual?
Just want to ask this quick question. Can our devices, mobile phones, or can these have an effect? Can it upset the mental capabilities?
Depends in what way we use mobile devices. So if our routine and habits are to utilize, as I say, tablets, phones, anything with a screen in excess, perhaps that can influence us in certain ways. Sleep patterns can change. So electronic devices create to simplify, a blue light so that we can see the screen in a certain way, but that blue light mimics daylight. So if we're constantly on the electronic devices into the night, as we were saying, people tend to try and watch something or read a news article now before bed, that will cause sleep changes. It can do. Not everyone will have that impact unless there was some risk to developing those difficulties. But I wouldn't say the electronic device itself has some type of electrical wavelength that's going to disturb us. I wouldn't say that.
Okay. Hello, doctor. Two questions. I heard you mention about infancy and depression. And that was shocking to me. I wanted to elaborate a little more on that.
It's a very rare situation. So when we think of infants, 0 to 3 years old, you think of the developmental process for them. So walking, talking is roughly around the 1 year mark. Simple phrases. What we're thinking about is the nurture and care that one is having. So if an individual is not meeting their developmental milestones, what is the care that the infant is having? And then if they are being neglected, if they are not having that attention that is required to understand social engagements, that can cause a disruption, and you'll see more perhaps tearfulness, crying, maybe they're not sitting as much, maybe they're more floppy. There are more worrying aspects about it. So the infants aren't going to express things like, I'm sad, and the facial experience won't be the same as a child or an adolescent, but there are things about the influencing factors to them. Then as you get older, children become more communicative, understand social cues, understand what's social functioning, meeting people. Then you can see in a different way of how that engagement is.
Thank you. And then the second one is in terms of children and adolescent, yeah? When you look at anything in terms of mental health, it is so hard to get help for children. I think it's better getting help if you're an adult, I find, because you go to the GP and they refer you to CAMS. Now CAMS is overburdened, overrun, and so you have children on waiting lists for maybe 18 months, where in that process, in that period of time, everything is going worse. So is there any other services available for children except CAMS?
It would be looking at, well, I think the first point you're making is around the service provision. So when we think about appropriate services, CAMS, child and adolescents mental health services, that would be an appropriate service when one is going through difficulties related to mood changes, psychosis, behavioral changes, to ensure the right assessments are done. As we were thinking about autism, LD, and then ways of development, because the brain is not fully formed until we're in our early 20s. So it continues to progress, it continues to absorb everything that we're learning, and then our psyche, our personality, all forms around that. And you'll see that when you see children, or if you reflect on yourselves, how you grew up, changing patterns, interests, dress sense, all of those things were continuing to develop until we get a sense of ourselves. With children in this local area, when there's still a difficulty arising and perhaps parents are observing something's not quite the same as they were, CAMS is the appropriate service for that review. When we're thinking what else could be done whilst they're on a waiting list, I think is the query, that times could be longer because we're waiting on maybe that autism assessment, the LD assessment. That is a frustration that is shared by the professionals. They wish to see things concluded and supported as soon as possible. School services will have counsellors. School services will have the SEN workers, special education needs workers. So there are interventions that happen to assist there. And then whether there's local talking groups, they tend to be other things where children can go to have some community aspects as well. I don't think there's an alternative service to a professional service such as CAMS when we need to very specifically address what could be happening. And it's why you wouldn't necessarily see certain diagnoses that adults will have while a child is still developing. So you may not necessarily go, oh, this has a psychotic flair towards it, a mood flair towards it. Everything is still emerging, and perhaps the child is still trying to find the way they should be interacting, still trying to find a way of communicating when something's distressing. And that's why it takes time sometimes under CAMS to continue to see the evolution, see how a person grows and develops before formally giving a diagnosis.
Yes, doctor, let me tell you something. I want to know something. Can you tell me how people become dementia? And second question is, what kind of medication can that person use for dementia? What do you really give people or help people to get rid of dementia? Can you get rid of that, or is something doctors can really help out, or whatever?
So the first question is, how does dementia develop?
Yeah.
And then what the treatments are possibly for it, if you can cure dementia. Yeah.
And what kind of treatment can you do for, what you do to help the dementia, to get rid of it, or to help somebody with dementia?
Sometimes it's not very well understood how certain pathology can arise. So why does one person develop diabetes and another doesn't? Why does, within the same family, one person develop this and not another? So it may not be something that you can say, oh, we should do this to prevent it arising. But when we think of treatments, particularly with memory impairments, Alzheimer's, it's more about delaying the progression of its worsening. There isn't a cure for dementia or Alzheimer's, but there are treatments that help to reduce that progress or the worsening of it. And often it's looking at changes for adapting the environment, providing supportive care around, making things much more clearer, a routine to be formed so that things feel less distressing, less chaotic, and more comforting. So you'll see those parts often as the main treatment, alongside perhaps some of the other symptoms of a chronic health condition. So when we were saying that you may have chronic health difficulties, then alongside that, maybe feeling more anxious, feeling depressed, they can give treatments to focus on those particular symptoms. But at the core is the chronic health that needs to be reviewed.
Thank you. 1 minute. The reason I'm saying this is because my last sister is very ill at the moment. And then her husband has taken her to the doctor for sometimes. And the doctor declares that he can't find or see nothing wrong with this lady. But unfortunately, he always gave her some medication. If you don't know what I'm suffering with, why could I get you give me the medication to? Or what? What is the reason of giving me that medication? So that medication has been given to her, has caused her to become dementia. Yeah?
Caused her to become...
I really don't understand. And then, once he gave her some medication, and the medication was causing her to eat like an animal. Every minute, every second, every hour. When I phoned my brother-in-law, I said to him, how my sister is eating every minute, all night long. I said, can you imagine? I said, what kind of husband are you? Sorry to tell you. Oh, you have no common sense. If the doctor gives you some medication, as soon as you try the medication once or twice, you notice this is not working for you. Why are you still giving it to her? Will you please stop the medication? Get rid of it for me now.
It sounds like a very confusing and worrying time, and trying to understand what would be helpful for your family to overcome their difficulties. Again, it's very difficult to comment on treatments or diagnosis without knowing the case, but my advice would be to ask your sister's husband to speak to the doctor to understand, are they giving it for a particular diagnosis or symptom management, and what is the expectation from that. But there aren't medications that I would say will cause dementia, but there are medicines that might disturb focus, and that could be a side effect of it, but the doctor will be able to advise, or on the medication leaflet it will say, is there something that disturbs focus? So that could be a way to look into it.
Sorry. You mentioned about seeking help from the GP if you're worried about someone with depression, and what we found working within the community is if it's an adult and they're not consenting, it's really difficult to have those conversations with the GP, and therefore sometimes we're having to watch someone deteriorate right in front of our eyes, and yet we're trying to seek help, but we can't get the help because they're not consenting, and it just becomes a cycle. What can we do? Are there any self-help guides? Is there anything that we can access, or is there any point where it becomes, I don't know, where they can, not section, because it's not at a point of sectioning someone, but where you can force someone to get some treatment or some help.
I really feel for those situations, because it's about the severity of a difficulty and the impetus on an individual recognizing something's changing when others are noticing those. And it can be very worrying for those around the individual, saying, oh, you're not quite managing as well. Perhaps it's about highlighting what is being observed, perhaps giving advice that maybe some time away from that particular stressor could be helpful. So they're struggling at work, maybe you would want to take... So it's giving the advice, raising that awareness that something's not quite right, we're noticing it, we think it could be helpful to speak to your GP. And perhaps now with, again, the benefit of technology is there are websites. So NHS, if you go to the NHS website, it will have depression, and that link could allow the individual to read through what could be there and have an affinity, a connection to, yes, I kind of have this problem, how would they manage it? Because the flip side is the person going through things wants to try and manage, they're withdrawing from others, they want to try and overcome it. And that's what we're talking about, that spiraling, getting down. Rightly so, as you pointed out, it would not be section psychiatrists coming in and interfering then, because it's about the daily functioning. So as I said, when starting to change, that's where, as things are more emerging, highlighting to the individual, or then highlighting GP saying, oh, well, this is not working anymore. They're really struggling financially because work has been laid off. They're not looking after themselves. Could a home visit by the GP be arrived, because these are the risks we're seeing. We followed the advice where we tried for 2 weeks, 3 weeks, and we've noticed these symptoms for greater than the 2-week period. So those are usually very helpful for the GP to then go, okay, something more is happening here. Can I come and immediately do something? Do I need to speak to the local health services, psychiatrist, to think about this individual as well? But it's a very difficult situation when you're recognizing something's changing, you want to help someone, nip it in the bud. Sometimes it is very sad to see things have to get to a certain point for actions to then come through. But as I said, that first 2 weeks, sometimes people recognize it and spontaneously they feel better because they've had some people supporting or hearing their voice heard around it. Once it's going past that 2 weeks and you're seeing more changes, definitely the GP should be able to help with it, depending on the area. Because I know certain GPs don't do home visits, other GPs harder to get on the phone to get through. So I appreciate those difficulties, and why this awareness is helpful, because then maybe going and checking in on your colleague there, helping them maybe with their food shopping or their meals, and saying, look, I'm doing these things because I care for you, because I recognize something's not right at this point. And those interventions can help them to go, you know what, maybe I should see someone to help me overcome this. Those first steps help to reduce that stigma, that worry that mental health may have. And that's where this is a helpful step forward, these kind of discussions.
I just want to come back to my sister's question, because I don't think you addressed it. She asked the question, can dementia be cured? Are there any cases where dementia has been cured?
Not from my understanding. It's researched and reviewed, but it's a worsening prognosis. Over time it worsens.
Yeah.
And that's why the treatments given are meant to delay such a change, and why the importance is to stick with treatments to stay as well as possible. There is research looking into things to see, can they adapt certain novel therapies or treatments, but nothing that I'm aware of that would be currently applicable.
There's two hands. I think sister.
What is bipolar, and how do you recognize it? What's the symptom for it? What's the difference between somebody depressed and who's bipolar?
Bipolar affective disorder, so it's a mood disorder, meaning the regulation of mood is not as in control with the individual. Very similar pathology to depression. You'll have those lows. So the symptoms we talked about today, depression will be part of bipolar. And it can be indistinguishable in that point. However, for someone to have bipolar, they need to have had at least one episode of mania, which is all the symptoms we talk about depression, flip it the other way around. So low mood, super energized, super happy, everything is fantastical, colors are brighter, things are more pleasurable, more risk-taking, more socializing, maybe quicker to get irritable. I don't need sleep because I'm always energized, can do everything at once, fantastical creativity. The symptoms would have to stay for a good week or so to say this is mania, or the intensity for a few days to say mania. And then when you've had one episode of mania, or depression and then mania, we talk about that as bipolar. Then the treatments could be different. Sometimes it's having an antidepressant because you have the depressive lows. Sometimes it's other treatments. Mood stabilizers are usually a latter course, but an antipsychotic helps to control the mood poles in that as well.
How do you break the conversation with someone that probably has this symptom?
Depends in what context. So if you as a family member are noticing it, it might be helping them recognize something is changing for them, and whether they will engage, as our other audience member was saying, if I'm noticing, how do I get that help? And then thinking about what is the risks that may be arising. So someone who's manic, taking risks and really chaotic, that wouldn't be something I would say leave it to the family to manage. I'd say call for assistance, call the emergency services, and they will guide on what the next principle should be. So should the ambulance come? Would a psychiatrist come? And then they will help to review it. But that doesn't always mean everyone has to follow that process. It depends on the situation, and usually a telephone call to a professional helps to guide on what to do.
What if they don't want to admit that they might have?
Sorry?
What if they don't want to admit that there is a possibility and they know perhaps themselves, but they suspect that they have that kind of condition, but they don't want to talk about it, and they deny, they live in denial with it?
I would generally say it's a similar principle to the last question.
No,
so someone
not at all. I'm talking about bipolar.
I would say that the principles are very similar in that helping someone recognize something is changing, recognizing what are the worrying risks for that individual.
No, but I'm talking about they know themselves. They know that.
It's the same principle.
You know yourself that there is a change. 1 minute you're here, 1 minute you're not there, and then you're some. So you actually, as an individual, I mean, personally, I would think, hold on a minute. I would start questioning myself, and because it's not part of your makeup, so you know the way you react normally and interact with people. But if there is a change of attitude, then you will know yourself. But some people, they don't want to admit that there is something wrong with them. And what they do is they try to make excuses, or they use reverse psychology and try to say to the other person that there's something to do out there with the world. It's actually somebody else's problem. There's nothing wrong with them, but it's out there. So how do you help someone like that?
As I was saying, it would be the same principles, which is about helping raise awareness that something is changing with that person. If they're disengaging, they don't feel that's the case, it's then raising the awareness to the professional bodies around, emergency services or the GP, or escalating. But that depends on what is changing in their risks. So is it a dysfunction in their daily functioning? Are they putting themselves in any harm, or they're missing things there? Because then other professional bodies can come to review a person who doesn't feel something is wrong, or is masking, is manipulating the situation.
Is there something in your expertise that's called passive autism or aggressive autism that may lead to depression?
What is your understanding of passive and aggressive
passive
autism?
meaning they're saying that there is autism, there might be autism, but it's not showing. It's not showing, the person is not showing that there is autism, but there is autism. Because it's so calm, they're so calm, but it looks like there's depression leading to that. What I'm trying to say is they're saying, the doctors or whoever are saying the person might be autistic, but it's not showing it. It's as if it's passive, it's there, it's not aggressive to say, well, the person is autistic and running everywhere, but there is autism there, and that may be the cause of depression.
Autism is a spectrum,
Yeah.
autistic spectrum disorder. It's like a mixer deck, so it's not low intensity, severe intensity. Different features can be up and down for different people. So the classical understanding of autism is, someone's very attuned to a particular hobby, they will know everything about it, they'll have social communication difficulties, so it's an odd way of communicating, they may become irritable when things aren't going their way or routine is broken. That's a classical view of autism, that's not correct. Some people, again, classical view, loud noises sets them off into irritability. I know patients or clients with autism who are DJs, who listen to loud music. I know people who thrive within communication. That's where the understanding needs to be updated. When I've not used the term passive or aggressive, what I would suggest is if the individual has not been fully assessed, we call it suspected autism, and anyone who may have those characteristics can still be formulated and followed with what we would do with those who have the formal diagnosis. And education around, for the individual, what to do in different circumstances, social circumstances, schooling, work, they can be educated on what adaptations will be helpful directly to them, because it's not each person is individual. So what may work for person A will not work for person B. So the assessments should be concluded, the views can still be adapted and help the individual realize and maximize the benefits and potentials to fit in to the social norms that are in place, but there shouldn't be barriers for them to achieve what they can do. Does that make sense? Yeah. The thing is, with autism, I can do a whole lecture on autism, but it takes, I need time to then discuss it. So the way to think about it is, first, it's a child who is still growing, developing, trying to understand social cues and engagements, and then their characteristic on top is this spectrum aspect, and then seeing how do they cope in situations, what helps them to manage, how do they stay within those social situations to learn and develop. So there are two parts there. One is a growing child. They are a child, not to think of them as they have autism and forgetting the individual. And then the other is adapting to support them to maximize to engage in those settings.
Right, can I just interject for a second, Doctor? Right, we've got 4 hands, okay? How much time do you have? I've got to think of you.
Another 10 minutes, I could
10 minutes, okay. All right, I'm going to try and see what we can do. Okay, so please, everyone, be brief with your questions.
Oh, just to say, I'd be very happy to come back to talk about autism and ADHD. And my colleague, Dr. Iola, he's very experienced in this, and he may wish to come in and provide that as well. I think he sent his apologies because he wanted to participate today as well.
Okay, right here. Good afternoon, Doctor. This is really a quick question. If you know someone who has slight onset of dementia, what can you actually do to stop it in its tracks? Thank you.
So early recognition, to get health services involved, looking at whether there's community support that needs to be provided to assist the family if the loved one is at the home environment. They can then review the symptoms and the management resources to see what specific medications could be helpful, but ultimately it's the environmental changes and care package, support package to help someone.
doctor, I just want to know, depression and anxiety, is it the same? And also, if you want to manage it with that medication, is that possible?
Yes. So there's always a possibility to manage either of those symptoms. So feeling low or feeling anxious, there are ways to manage without medication. But to do that, it's best to have the advice from the GP and what you're wanting to achieve. Because if it is a certain situation that we're feeling anxious, it's hopefully trying to learn to overcome that distress. They can guide with psychological management. Depression, talking therapies, psychological management, both conditions could be supported. But as I said, with depression, specifically here, the severity of the symptoms may say, well, we're trying this, we're watching and waiting, we're trying psychology, has that helped? Are they still struggling to overcome this? Could medication then be supportive? And at what point do we want to come off of medication? But again, with the guidance of the prescriber. With anxiety, things can overlap to different degrees, and it's understanding where does the anxiety come from. Is it its own condition, or is it part of the stressor we've gone through, part of the depression? And that's where a clinician talking with you would be able to delineate both of those.
You know, earlier you said that some people use substance to mask their depression. Why is it so difficult that you know an individual has that issue and the person, yes, identified it, goes through the professionals, and it has been identified? Why is it so difficult for mental health services, consultant, nurses, to recognize that this person has a problem and need that help? Because the first thing you kept getting this knockback, as Grace said earlier, that you identify the problem with the individual, but they don't want to acknowledge it. But these people acknowledges it, but the mental health service keep knocking them back to say that you're using substance. Substance is the problem. And it's not really substance which is the problem, but depression. Why is that the case?
So each situation for a client could be very different, and it depends on what, when we talk about substances, alcohol or drugs, we'll have different ways of managing or supporting with. So if there's a primary depressive symptom, there'll be treatments for that. But if on top of that someone is developing a coping strategy of utilizing substances, not only does it impact the way the treatments work, may make it work too effectively and go into side effect risks, or may not make it work at all. And then the substance itself may cause depressive effects, anxiety effects, depending on what it is. So alcohol is a depressant. So if on top of feeling low, we're also having alcohol, it perpetuates feeling down. And so the view that the medication's not working, that's where it'll be highlighting, say, but we're also using something on top of that that we need to remove to then review, is it the medication, something else? But for mental health services, the services that support with substances are a subset. In this local area will be Change Grow Live, CGL, and they'll provide assistance with alcohol or non-prescription addictions. So if we think of cannabis, heroin, those things. Targeting those to reduce the coping. So when I speak with my clients, I'll ask, what is the purpose of substances, alcohol? What do you gain from it? Because we're using it for a purpose. So we want to understand, what are we trying to gain from it? And has that still continued? Some point it might have been beneficial. Helps me to fall asleep, helps me to forget the stresses I'm in. But when I wake up, I still have that situation. It comes back. So it's not a progressive management, and then drinking more to try and maintain it longer causes things to become more dysfunctional. So now we have to target the management for, let's say, alcohol, so that we can then progress towards thinking about what was the perpetuating worry, and is that around psychology to talk about it, instead of turning towards the solution we've tried, alcohol. Let's turn towards psychology and start processing the worry, start processing the difficulty there, and using that as the positivity going forward. We want quick fixes. Anyone, I would want something to quickly fix what is the difficulty I'm going through. And sometimes that's not always the possibility. In depression, that's not always a possibility. It takes time. The healing takes time. Some of the issues we go through may take time. And substances may quickly impact us to forget for that moment. And that's where we need to learn that it's not always the best way going forward. And how do we change our learnt coping strategy towards one that will be much more long-standing to benefit us.
You know, as you said that, I like the way how you say, but my experience with my type of client group is just that mental health services just push them away. They don't want to know. As long as they're drinking, they just don't want to know. So it's good that you are saying that they can refer them to the drug and alcohol services or the treatments that are available. But they just don't want to know. As long as they're using substance, they don't want to know.
I would want to know who the clients are, because what may be happening is an expectation from that clinician working with them is not being met. So they're saying, I want some ultimate solution straight away, but you're telling me to go and work with this service for 4 months before I can get the next change. And it's that time period again. I want a medication to change now. That could be a situation. It might be they are upset that they're still in a difficult position, and maybe it's social care management to assist them. So the answers are not always with the doctor. Maybe it's the guidance that's provided to assist them to know that there are other services that can help when well-being is not always about the mental stability. So well-being gets enmeshed within mental health, but well-being can be affected by our social circumstances, housing, finances, and the doctor is not the one that's going to be able to change that. There are different services that help to guide to it. And so when the situation is still playing out that you've not given me the answer, you're telling me to go here, perhaps they feel rejected. You've not given me a solution, you've asked me to go elsewhere. I think that could be one of the positions. Thank you.
Could you give Dr. Kaj a hand? I'd like to thank each and every one for coming this afternoon. I'd like to thank Dr. Kaj for coming away from Tooting on public transport to get here. It's not 15-minute drive from there to here. So thank you very much, Dr. Kaj. One thing I can assure you of is we're putting together a panel of all the speakers for the month, and they'll be back at the end of this month. So you can do a number of things. Write your questions down, so that you can target Dr. Kaj with any specific question that deals with his particular sphere of expertise. And also, you can also mull over all that he's had to say, because he said a lot. And hopefully it will have made us better individuals in terms of our knowledge, in terms of mental health along the lines of depression. And if we do speak to our loved ones about it, we can actually see if there's any changes, like what Dr. Kaj mentioned, and also signpost them to the relevant professionals so that they can get assistance. Thank you again, Dr. Kaj. Next week, we'll be looking at diabetes. Are you at risk? And Dr. Tony Anal from Whips Cross, he's an A&E doctor, will be here to speak to us on diabetes. Speak to your friends and acquaintances, whether they have diabetes or not. Ask them to come, because this month is Health Emphasis Month, and all of us are seeking to be healthy as much as we can. And one way you can be healthy is have knowledge. Knowledge is the best form of empowering us to be healthy. That's if we take the advice that is given. But in the interim, we're trying to give that advice so we can be healthy individuals and also support other persons who we would hope we can help to be healthy as well. So shall we stand? And shall we pray? Gracious Father, thank you yet again for your love, your mercy. Thank you for Dr. Kaj and the knowledge that he's given us, dear Lord. I pray, Lord, to use whatever he's given us through you to enable us to be more healthy and also pass information on to other individuals as well. As we're about to leave, Lord, go with us. I pray that you'll guide us, protect us from evil that may approach us, and help us have a great week. In your precious name I pray. Amen.